So today's seminar covers an area of research that is often overlooked: ADHD in people in middle age and older age. ADHD is often associated with childhood, and we know that it gets into the news a lot, but for many people, its impact can actually last a lifetime. And we know surprisingly little about how ADHD affects health as we get older. But research is already revealing important new insights. So I'm absolutely delighted to be joined by one of our funded researchers, who's also supported by Advent, to talk about what the current research tells us about ageing and ADHD. So you will see that Dr. Amber John from the University of Liverpool has just popped on screen. Amber, please could you give a short introduction to yourself, to the audience in your own words, and then please go ahead and continue with your presentation. Over to you.
Thanks so much, Rebecca. Hi, everyone. I'm Amber. I'm a senior lecturer at the University of Liverpool, and my research is largely around ageing and mental health, and particularly in the context of people with ADHD. And what I'm going to be talking about today is a research project that's been funded by the Medical Research Foundation that's aiming to better understand the experiences of ADHD in people who are aged 50 and older. So firstly, today I'm going to talk about why this topic matters. So why do we need to think about ADHD and aging? Then I'm going to talk about some of our research looking at recognition and diagnosis of ADHD in primary care and what the data show us. I'm going to talk a bit about some of the life course consequences of ADHD, so thinking about inequalities that people with ADHD might experience across the course of their lives. And then I'm going to talk about some early kind of findings from lived experience. There's only so much that statistics and numbers can tell us. So we're doing some research, trying to hear in people's own words what their experiences look like. So I'll share some early findings from this too. And then at the end, I'll just bring it all together about what it all means and what are the implications of all this. So just a bit of background. So ADHD historically has very much been framed as a childhood condition, but increasingly we're recognizing that ADHD isn't something that people grow out of really. It's something that persists across the lifespan, although traits or symptoms might fluctuate across the course of people's lives. It is something that stays with people. So child with ADHD will likely grow into an adult with ADHD and eventually into an older adult with ADHD. But despite this, adults who are in middle and older age are largely invisible in research, in clinical practice and diagnosis, and healthcare services. We actually know very little about this group. And unfortunately, a lot of the research into ADHD kind of seems to end in early adulthood. Very much the research and the evidence base at the moment is based on children and increasingly in younger adults, but we know remarkably little about people older than this. So to kind of understand this better about what research is being done, we've done a review looking at age trends in ADHD research. So essentially we did a big systematic search of all the peer-reviewed literature that's been published on ADHD, and we kind of classified it into age groups. So research focusing on ADHD in childhood and early life, adolescence, adulthood, and then kind of middle age and older age. And we found a real clear gap in the research. So actually, in terms of newly published research each year, kind of the work that focuses on this age group of middle and older age actually is less than 1% each year of that research. And if we take into account all of the research that's been done, research focusing on this age group actually makes up less than about 0.1%. So it's very much a gap in the existing evidence. So I'm going to talk a bit about diagnosis rates of ADHD in middle and older age in England. So we managed to get data from kind of primary care records in England. So this includes people that are registered with GP practices across kind of the entirety of England. It includes 17 million currently registered patients, which is actually about nearly a third of the English population. So it's a really big data set, and it's really helpful to kind of understand what's going on in terms of ADHD diagnosis across the country. So what we found was that, as expected, when we look at diagnosis over time, this is increasing. So we can see it's kind of low and stable-ish, a bit of a slope up to about 2020. But from 2020, we see this kind of marked increase in ADHD diagnosis. However, when we divided this by age group, so here we have the same graph as earlier, but separated by sex. So this is the data for females, and then on the right, we have the data for males. And we see kind of diagnosis rates over time. And each colored line represents a different age group. So what's interesting here is when we look at the age 65 plus age group, that's that pink line, we can see that diagnosis rates have remained really low and really stable in this group. So although we're seeing this increase in ADHD diagnosis, this is really being driven by younger people. And actually, there seems to be kind of a lot less recognition in these older groups. When we looked at a specific point in time, so we took mid-2025, and we looked at that point how many people across our data set of people registered with GP practices had a diagnosis of ADHD. And we found that about just over 1%, about 1.19% of people had a recorded diagnosis of ADHD. And we also looked at this divided by sex and age group. And then what we did was we compared these diagnosis rates to estimates of how common ADHD actually is in the population. And we took kind of estimates that were specific to sex and age group to make it comparable. So we wanted to see what does that diagnostic gap look like for different groups. What we found was that diagnosis rates were really quite substantially lower than expected kind of rates of how common ADHD actually is in the population. But this gap differed depending on age. So what's really interesting is when we look at this older adulthood period, again, age 65 plus, we can see that we estimate that over 90% of people of this age group who would likely meet the criteria for an ADHD diagnosis are likely to be living without a diagnosis or without recognition. So there's lots of reasons why this might be, why kind of older people and people in middle age are kind of more likely to be overlooked or missed or undiagnosed. In particular, there is a known kind of lack of awareness historically. So a lot of people of this age group would have grown up in a time when ADHD was, very poorly understood, when it was highly, highly stigmatized, or when it was simply not recognized or not known about at all. So what this means is that as awareness has begun to increase more recently, a lot of people of this age group have left kind of childhood, left education, which is kind of the time when traditionally ADHD is most likely to be recognized. So a lot of people tell us that they feel that they've almost missed the window for this kind of recognition. We also know that diagnostic stereotypes contribute, as well as kind of the changing diagnostic criteria for ADHD over time. So early descriptions of ADHD were largely based around kind of behaviors in young boys that were perceived as hyperactive or quite visible differences. We now know that that ADHD is much broader than this, that there's lots of different presentations of ADHD and that it affects a diverse range of people. And our diagnostic criteria have kind of caught up with this. But when people were growing up with those diagnostic criteria and those stereotypes, if they didn't fit into that kind of stereotype, then this is a reason why they may have been missed for a long period of time. Masking is another kind of important thing, is that a lot of people who went without recognition of their ADHD for a long time may have learned to mask or hide their ADHD traits or characteristics. A lot of people tell us that they've developed and built compensatory strategies, essentially to help them get through life. The problem here is that it might make diagnosis or recognition of ADHD harder, because from an outside perspective, people might not see kind of the inner challenges and experiences that people face. And that's really important, because we can't underestimate the amount of energy and effort and invisible work goes into these kind of masking behaviors. So it can be detrimental in the long run for some people. And then finally, so people that were missed in childhood, even if they kind of seek help in adulthood, a lot of people have been given kind of alternative explanations for their experiences. So ADHD traits might be misattributed to other kinds of mental health problems like anxiety, depression, personality difficulties, and also, interestingly, things like cognitive aging and dementia. So what this means is that a lot of people might end up with a diagnosis that doesn't quite fit their experiences. So that's what we see in the data in terms of diagnosis and the potential explanations for why older people have been overlooked for so long. Now I'm going to talk about some of our research aiming to kind of follow people with ADHD and see what kind of their experiences look like as they enter into middle age and inequalities that they might face. So we wanted to look at health outcomes first. So what we did was we used the same data set that I described earlier. This time it included about 500,000 people. They were people, adults in England, who were registered with GP practices. And we had the sample of people that had a recorded diagnosis of ADHD, and then a kind of matched comparison group without a record of ADHD. And then we picked 8 kind of health conditions that are ranked as being some of the top most disabling conditions. And we looked to see whether they were more common in the ADHD group compared with the non-ADHD group. And what we found was that this was the case. So it was the case for all 8 of these conditions: anxiety, depression, self-harm, harmful alcohol use, substance use, migraine, chronic back pain, and gynecological conditions were all more common in the ADHD group. And what was really stark was some of the size of the gap for some of these conditions. So particularly when we look at anxiety and depression, actually over half of the sample with ADHD had a record of these mental health conditions. Now, this is interesting because it may be that they're more likely to experience anxiety and depression, but as I talked about earlier, it also could be that these diagnoses were received prior to an ADHD diagnosis. So that's something to bear in mind. We also looked at the rate of new diagnoses of all of these 8 conditions to see whether people with ADHD were getting more kind of new diagnoses of all of these. And we found that this was the case across all 8 conditions. So particularly for substance use and self-harm, so substance use, people with ADHD had 4.5 times the likelihood of a new diagnosis of substance use compared to people without ADHD. And in self-harm, this was 3.78 times more likely. So we can see that there's clear differences in these kind of health outcomes between those with ADHD and those without. But how does age play into this? So we wanted to see whether the relationship between ADHD and these health outcomes differed depending on people's age. We found that this was the case for anxiety and depression only. So what we found was that ADHD was actually more strongly associated with depression and anxiety at older ages. So this kind of suggests that some of these mental health inequalities may actually widen with age. So I guess that leads on to the really important question, which is why? Why do we see these increased mental health problems in people with ADHD? So we wanted to look at societal exclusion as a potential kind of explanation for this. So when I'm talking about societal exclusion, what I mean is it's kind of defined as systemic disadvantage that people experience, as well as kind of avoidable barriers that people face that might make it harder for them to kind of fully participate in society. And this can happen across lots of different areas of life. So we might face societal exclusion in kind of our relationships, or in our access to services, or our kind of education or employment, all these kinds of things. So to test this question, we analysed data from over 9,000 people who had been followed from birth right through to age 46. So we had this really rich data following people all the way from kind of when they were a baby right through to kind of early middle age. What we found was that people with higher traits of ADHD in childhood were more likely to experience a higher level, as well as more persistent problems with their mental health and with psychological distress. But so this is very much in line with the previous findings and what we know about ADHD more generally. But what was really interesting was that when we included societal exclusion, we found that this kind of in part explained the relationship between kind of ADHD traits and middle-age mental health problems. So it suggests that actually some of the mental health problems that people with ADHD face aren't just caused by, ADHD traits and the kind of knock-on consequences, but also are shaped by the environments and the barriers that people come across through their lives. So we know that mental health problems are more common in ADHD, and that these mental health problems might increase as people get older. So I guess the clinically important question is, what do we do about that? And are existing kind of psychological therapy services working well for people with ADHD? So I want to start off by describing this particular service. So it's a service offered in the NHS called NHS Talking Therapies for Anxiety and Depression, which is short for NHS TTAD. So this is kind of the first line service that people are referred to if they present with symptoms of anxiety or depression. I think it sees seen about 8 million people, so it sees a lot of people, including people with ADHD and people without. So we got access to the national data for everyone that had been referred into these NHS talking therapies for anxiety and depression. And we were able to link this to kind of other health records to identify whether or not people had a diagnosis of ADHD. So we found that people, compared to people without this record, people with ADHD were less likely to have an assessment once referred, so less likely to be assessed in terms of what their needs are. After their assessment, they were also significantly less likely to actually enter therapy and get treatment. And then once they were in treatment, they were less likely to actually recover from their symptoms of anxiety and depression. We also looked at the kind of recorded reasons why people were discharged. And we found that this was the most common kind of reason in ADHD compared to non-ADHD, was that people were told that the service was not suitable. Unfortunately, we don't have information about why the service was considered not suitable, but this was kind of the biggest difference between the groups. We did look to see whether these effects differ based on age, but they didn't. Actually, this finding was consistent across all age groups. So what this shows is that there really seem to be kind of barriers for people with ADHD that have depression and anxiety at all stages of life. So when they come into this service, they seem to experience inequalities right from referral through to discharge. Whether that is in access in terms of getting into treatment in the first place, or once in treatment, being able to actually benefit and improve symptoms. The likely reason for this is that these services haven't been designed with neurodivergent people in mind, including people with ADHD. And they're often not adapted to meet the needs of these people. So without these kind of reasonable adaptations, people might face increased barriers and find it harder to kind of benefit. Okay, so this is what the data show. I want to say that up to this point, I've been talking very much about population level trends. So we know that many people with ADHD really thrive and do well through their lives, and they find the strengths associated with ADHD that many people experience. But what I'm talking about is at a population level, how this looks, rather than individual level experiences. But it's really important to hear what people have to say about their own experiences, because as I said before, statistics and data and numbers, it tells us a really important story, but what we don't hear about is why or what things really look like through the eyes of people with ADHD. So we did some work where we interviewed 20 people who were over the age of 50 who had ADHD. And we asked them about their experiences kind of across their lives living with ADHD, their kind of diagnosis experiences, if applicable, and about their kind of hopes and worries about the future. So this work is ongoing, I should say. My research assistant, Lucy, is working incredibly hard doing the analysis at the moment. But we do have some preliminary kind of findings or insights that I thought I'd share with you here today. So the first kind of main theme or insight that seems to be coming out of the data is the changing nature of ADHD across the course of people's lives. So some people described that ADHD traits had been with them their whole lives, but that the intensity of this had kind of fluctuated and changed as they got older. Some people talked about ADHD becoming more noticeable or harder to manage in middle age and kind of later life. Menopause and perimenopause was really commonly talked about. I think all or nearly all of the women that we interviewed talked about this and described it as being a really major turning point in their lives that interacted in a kind of important way with their ADHD. And a lot of people reflected on kind of long-standing patterns of ADHD related traits across their lives and kind of were looking back at their lives applying kind of the lens of ADHD. So I've included some quotes from people that we interviewed to kind of highlight some of these points. So somebody said, "Now looking at myself at age 12, all the basic stuff that ran through my life, great ideas that failed to execute." Somebody else said, "Everything changed at menopause. Where I'd been able to cope, suddenly it was like I couldn't." And then somebody else said, "It's just feeling like it's unraveling a bit the last 10 years. So we can really see kind of the changing nature of ADHD and how this fluctuates over time and how it interacts with some major life experiences that people face as they get older. The next kind of theme or preliminary insight that we're kind of seeing is people really describing these lifelong barriers and experiences of misunderstanding and being misunderstood. So people described these really long-standing experiences of masking, burnout, feeling invalidated over kind of decades of their lives. In particular, people talked a lot about being misunderstood in workplaces and in healthcare settings. People talked about environments and systems being particularly difficult for them to navigate. And thinking specifically about healthcare experiences, people talked a lot about sensory and communication barriers and how needs were not always kind of met in these healthcare settings. So some quotes from this theme. Somebody said, people say they are making adjustments and then they don't honour them. They can't even be bothered to engage with you. Somebody said, the vet knows more about dealing with me than the GP does. And then somebody said, the health service isn't designed for neurodivergent people. Waiting rooms feel like an endurance test because of being too bright, too loud. So some hard-hitting quotes here to highlight this. And then the final theme that I'm going to talk about today is around the meaning that people found of diagnosis and of recognition more broadly of ADHD later on in life. So for many people, diagnosis or recognition often brought this real sense of relief and self-understanding. People were able to become less critical of themselves and have less kind of self-blame. And people found that diagnosis helped to contextualize kind of the rest of their lives. So people looked back at kind of their childhood and their early life, and they were able to see it through a new lens and a new perspective, often with a lot more kind of compassion, understanding where some of those challenges came from. I think a lot of people felt that they had internalized a lot of kind of negative labels because of their ADHD traits never being fully recognized. So getting recognition or diagnosis later on helped to kind of to understand this a little bit better. However, some reflected on the cumulative emotional impacts of going so long without recognition and support, and that getting this later on didn't necessarily erase all of the kind of difficult experiences and lack of support and challenges that they'd had earlier in their lives. Some people felt that diagnosis in particular had been really helpful for them because it opened access to support, medication, which you can't really get without a diagnosis, and different kinds of coping strategies. Whereas others, particularly those who weren't interested in medication, felt that self-recognition, self-identification alone was sufficient and they didn't need kind of additional diagnosis. And that's important because people also really talked about barriers in the diagnosis process, particularly for people of their age. So bringing this together to finish up, what does it all mean? I think this work has really important implications in terms of clinical practice, for us as researchers, and also for kind of policy makers and policy professionals. In terms of clinical practice, we need to make sure that ADHD is not considered a childhood-only condition, and this is something that affects a diverse range of people, including people who are older, and that ADHD is not kind of ruled out on the basis of age alone. We also need to make sure that our diagnostic pathways for ADHD are age inclusive, and that people who are kind of middle-aged and older don't face disproportionate barriers to actually receiving this recognition. In terms of research, so older people, as I talked about earlier, really are missing from the evidence base. And this is a problem because it means that how we're working with people in practice isn't being informed by the literature and evidence. So we need more kind of research that is focused on aging and that follows people over longer periods of their lives. aiming to address some of these questions about ADHD later on, and particularly how this interacts with kind of transitions in people's lives later on, things like retirement, menopause, bereavement, increases in caring responsibilities, all of these sorts of things. And then finally, in terms of policy, I think it's really important at a policy level that we're thinking about neurodiversity-informed aging services. So increasingly, more and more people with ADHD are approaching kind of middle and older age. And yet our kind of healthcare services designed for this age group are really set up to deal with this. And this is going to be a real problem in the future moving forwards, unless we start to think about it now. There also needs to be better recognition in primary care and mental health services about this particular age group, so that they don't remain so invisible moving forwards. So just to reiterate, this work was supported by a grant from the Medical Research Foundation, so actually none of this would have been possible without them, so I'm so grateful. Thank you everyone for listening. I'm really happy to answer any questions that you might have. My email address is here as well, so if you want to chat about any of this, feel free to drop me an email. Thanks again. Oops.
Thank you so much, Amber. That was fascinating. It really was. And we've been getting lots of questions in, so clearly everyone else thinks so too. So I'm going to kick off straight away. So we have a question from Leah, who says, what does the literature say about the heritability of ADHD? Her little brother is currently being assessed and their mother has some significant ADHD symptoms herself, but doesn't feel confident in seeking a diagnosis as a middle-aged woman.
So that's a great question. Actually, ADHD is considered highly heritable, and it often kind of comes in families. And what's so interesting about your question is that it really aligns with what we've heard from a lot of these people in terms of routes to recognition, is that this is a really common way that people in middle and older age actually find out that they're ADHD, is that their child or their grandchild is diagnosed and they think, hang on, they're just like me. And this is something we hear again and again. So this is a common route through which people recognize ADHD in themselves. And we do know that ADHD is considered to be heritable. There's a significant genetic component involved.
Great, thank you. And then you touched on this at the beginning about kind of underdiagnosis in later life, but we have a question from Natasha who says, is ADHD underdiagnosed in later life because existing assessment tools do not adequately capture how ADHD traits change with age, or because people don't seek a diagnosis unless their symptoms significantly interfere with their daily lives and they need help managing them? So is there a balance between one or the other, or?
I think both. I think these are both excellent explanations and likely both at play. I think that there is less kind of support seeking in older people. We see this more generally in mental health. And this is likely due to differences in how neurodivergence and mental health were perceived and understood in kind of the past when they were younger. And also because of lack of awareness. So a lot of people don't necessarily know how ADHD looks at that age. So we may get less people seeking diagnosis in that age group. Also, there's a lot of stigma from kind of people around, particularly in that age group. That's something we heard a lot of in the interviews, is when people disclosed that they were thinking about ADHD, that people around them were like, well, what's the point of diagnosis at your age, or that kind of thing. So a lot of misconceptions. So I think that all of this contributes to less support seeking in this group. But I also think it's really important that I think a lot of our assessment tools, exactly as you say, have been designed not really thinking about older people and how they may present differently, particularly given different historical context and how traits fluctuate over time. So I think both.
Yeah, Okay, thank you. And we have a question from Neil asking, do you think a lot of the systemic navigation issues are down to comorbidities? So, for instance, with autism spectrum disorder, or do you think it is mostly down to the ADHD itself?
So again, I think that both are true. I think both are happening at the same time. So I think ADHD in itself can lead to people facing particular barriers. If you think about executive functioning difficulties that people might have, difficulties with planning and organisation, that can make attending healthcare appointments very difficult. That can make taking your prescribed medication really difficult without kind of support being put into place. But I think that there's definitely a double disadvantage at play where there are co-occurring conditions. We know that autism, for example, co-occurs frequently with ADHD, and that these people, again, this is kind of an overlooked group that we don't have much research, but from kind of the evidence that does exist, it's likely that these people kind of experience an additional disadvantage and different kinds of barriers. But also other co-occurring conditions like anxiety and depression, they all add kind of an additional burden for people being able to kind of access the services and the things that they need.
Yeah. Yeah, absolutely. Okay, so we have a message from Sean who says, these preliminary insights are really interesting. Sean is the head of service for Wales Neurodivergence Service and is currently working with Welsh Government on developing a neurodivergence code of practice. And the guidance will be written from a life course perspective to address some of these inequalities. So this is fantastic news. I can see that you're nodding. Sean says we are also looking to understand why diagnosis is so important to adults and older adults. The Older Persons Commissioner in Wales is very interested in this topic. Will these insights be published? And are we able to access and share this presentation to influence our work in Wales? Although research is based in England, it is very relevant to us here in Wales.
I'm delighted to hear this. I can't tell you how pleased this makes me. Yes, the work will be published. I believe the qualitative interviews were from across the UK as well, actually. So that might also apply quite well. I would ask, could you get in touch? If you email me, I can send you kind of updates as it's published and as it develops, because as I say, this is preliminary. But we hope in the next few months it will be certainly submitted for publication.
Fantastic. And Sian, just to let you know that this video will be available publicly afterwards, so that the link that we send you, you can share that. And then, yes, if you get in touch with Amber about the presentation and any publications, I'm sure she'll be able to help you out there. So just to let anyone know who hasn't yet found the Q&A button, that's how we're doing the questions today. So please do put your questions in there if you have any. I have a question, which I've been noting some things down as you were talking. So one thing I thought was really interesting right at the beginning is you looked at different conditions, both mental health and physical health, and you had chronic back pain and gynecological conditions being more common in ADHD, in the ADHD group, particularly the gynecological conditions. And I wondered how that is accounted for. Is that the health service is excluding these people from being able to get a diagnosis, or is there any evidence of kind of underlying shared mechanisms?
So I think it's likely working through kind of multiple pathways. So I didn't present here, but we did some other work looking at physical health outcomes in kind of middle age, again, finding kind of supportive evidence that people with ADHD in childhood were more likely to have kind of greater levels of physical health problems and greater kind of physical health related disability. And we looked at some of these mechanisms. So I think one potential explanation is through people with ADHD are more likely to engage with things like smoking as kind of the self, medication. They're more likely to struggle with things like eating and these lifestyle behaviors. They're more likely to have these mental health problems that we know also contribute to development of physical health problems. So I think all of these kind of lifestyle behaviors that go along with ADHD are one way through which some of these physical health problems may begin to develop. Another thing is, again, through kind of broader societal exclusion. So, for example, people who have ADHD might struggle in educational settings if they don't have the right support. They might struggle in their employment, and that can have a knock-on effect on someone's kind of financial position, what they're kind of able to access. And we know that all of these things are like very important predictors of physical health outcomes too. So this is kind of how the physical health problems might first begin to develop. But then we know that there's all these barriers in healthcare services. What this means is that people with ADHD might be more likely to go later for a problem when it's kind of at a worse stage, or maybe it's less likely to be recognized straight away and to get kind of early intervention or treatment. So people with ADHD are going longer and having kind of multiple appointments in order to get to the stage of diagnosis. So that's kind of in healthcare settings. And then I think the final thing is around, they might be given medication or treatment or self-management kind of programs in kind of healthcare. But then again, these can be very difficult for people with ADHD to really engage with without kind of support or scaffolding. And then again, this can make physical health problems kind of get worse. So I think all of these things together kind of contribute to some of those stark statistics we see.
A complex picture. Interesting. Okay, so we've got lots more questions to get through. We have one here, which is, thank you for your great presentation and for sharing such interesting studies. Could you please let us know how we can access the primary care data used in your study? So I don't know whether that's from a researcher or from a non-researcher, so you might need to talk about both instances.
So it's a data set called CPRD. I think it stands for Clinical Research Practice Database. Essentially, you go through a data access application. So you kind of write an application form where you tell them what you're going to do. It needs to be relatively detailed, but there is room for some flexibility. I think they just want to know that you're not just going to do loads of stuff, but go in with a specific research question. And then it goes through kind of review at their level. There is a payment involved for this, depending on if you're a researcher and if your university has kind of a license with them, and if your university requires you to pay. So in terms of payment, CPRD require it, but if you're at a university, there might be some flexibility with that. My MRF grant paid for this, so I was very fortunate. And then after that, they make the data available to you, and it's such a fun data set to work with. So if you can work with it, I really recommend it.
Great, thank you. Just to follow up on the previous discussion with the person in Wales, Carol has asked, would it be possible to notify attendees when the publication happens rather than bombarding Amber with separate emails? And actually, I would say that, yes, as soon as Amber lets us know at the foundation, we can communicate that out on our standard communication channels. So please do look out for those. So LinkedIn, Instagram, and our newsletter and so on.
Just to add to that, sorry, Rebecca, what might be interesting or useful to people is because there was such rich information, people were so generous with their kind of experiences, we've decided to separate it into two publications. So one focusing on experiences and aging and diagnosis, and then people had a lot to say about their experiences in healthcare. And we really want to do justice to that. So there'll be a second one, but I'll make sure that the Medical Research Foundation are aware of both.
Great, thank you. I have a question from Onu who says, what does the literature say about how a neurotypical individual can be a better, so more supportive friend to someone who has ADHD? So in situations where they feel particularly overwhelmed in a sensory sense. Is that something you can speak to?
So I'm not sure of literature in this area, certainly not in this age group. I don't think there would be anything. What I would say is that what's come out of the interviews is the importance of social relationships more broadly. But very interestingly, kind of a sub-theme that seems to be there is the importance of supportive relationships amongst neurodivergent others. So finding community and belonging with people that have kind of similar experiences and kind of shared life history. This is something that people found to be really valuable, finding that community. But I think more than whether someone is neurotypical or neurodivergent, people really seem to feel that it was the supportiveness of the relationship that was important, that it was someone that they felt valued around, where they, got this sense of belonging. And where people had the inverse of people meeting them with kind of skepticism or disbelief around their ADHD or not understanding or providing that kind of support, that was kind of people reported having quite negative experiences around this. So I'm not sure that's the very good answer, but I think that having neurodivergent people around you can be very helpful for some. But essentially, I think what it comes down to is how supportive and intimate that relationship is.
Yeah, great, thank you. Okay, I can't see all of the names, so it's a little bit tricky here, but oh yes, I have a question from Denise. I was thinking about the difference in gender in diagnosis of ADHD in older age. I seem to have spoken to a lot of females who have been diagnosed recently and wondered if there are more females coming forward for diagnosis. What are your thoughts about this?
I certainly think so, and I think this is in line with the data that I showed earlier. And I think what this has to do with is, again, a historical under-recognition of women and females, that the rates of ADHD in these groups were really, really low up until kind of the mid-2000s. And this doesn't mean that people at these times didn't have ADHD, but rather that they weren't being recognized, they weren't being identified. And so when we see this increasing kind of spike amongst women, I actually kind of see it as something of a bit of a success story, that people who weren't recognized earlier are now coming forwards, and that's why we're seeing this increase. It's not that ADHD itself is increasing, but rather that recognition of people with ADHD is increasing, and this is especially the case in women. What I would say, though, is that there still is substantial under-recognition amongst females. I say females because we only have the data on sex and not gender. So what was very interesting, though, was that in young people, we saw quite substantial sex differences where females were less likely to be recognised. But as people got older, that sex difference disappeared because rates were so low, both for males and females. But yes, certainly I think that women and females have faced particular barriers to diagnosis. This is beginning to improve with increasing awareness, but there's still work to do, I think, around this.
Brilliant, thank you. And we don't have time for any more questions, but thank you, Amber, so much for your presentation and for answering everyone's questions. It was a really, really interesting presentation, and I hope everyone out there enjoyed it too. Thank you to everyone for attending. And to hear about our life-changing research that the Foundation is funding and that Amber is doing. I'd also like to say a further thank you to Advent, who also supported Amber's research, specifically to their staff worldwide for their generous fundraising efforts, and to Advent for matching those gifts, which meant that we could fund more research. And research such as Amber's gets funded because of donations like that. And if you wish to make your own contribution to funding life-changing research, please consider making a donation to the Foundation. Thank you all for your ongoing support. And then if you'd like to learn more about this work and other research, please visit our website. And if you aren't already, please do consider signing up to hear from us via email. That way we can get the publication notification out to you from Amber's work. And you'll be the first to hear about future seminars like this one, as well as research news and other breakthroughs. So to remind you that we will email you all a recording of this session over the next few days, so you can share it or watch it back. I really hope you've enjoyed the seminar. Thank you all for attending, and thank you again, Amber, for a fantastic presentation.